So your level 1 outcomes are you need to be able to use normal sleep physiology to explain common sleep problems to children and their families. You need to be able to recognise, investigate and initiate management of sleep problems and recognise the importance of sleep routine and sleep hygiene. Next slide. So what is sleep? So if I ask you guys, I put a definition there, but we all sleep every day. But what actually happens when you fall asleep? So sleep is a reversible state of reduced awareness and a selective responsiveness to the environment. So when you're asleep, there is a degree of awareness that does persist. So if you think about the mother who can sleep through a thunderstorm but will wake when she hears her baby cry, so that there is still some awareness during sleep state. So my question to you guys is, which sense is most aware during sleep? Any ideas? I can't hear anything. So the sense that you're most aware of is hearing. Okay, so sound. The other thing about sleep is that there's a degree of motor inhibition. Okay, and sleep is species specific. There's a reason why I've put a dolphin there. Does anybody know why? So a dolphin is able to stay awake because it's able to put half of its brain to sleep and the other one stays in the awake state, and it swaps that over. And the reason why dolphins don't drown is because they're able to stay awake. Obviously we can't do that, but there are lots of other aquatic animals and birds that also do that are also able to switch off half of their brains or turn half of their brains into sleep state to allow rest. And the position that we sleep in is also quite variable, variable with different species as well. So you'll know whales sleep vertically and we sleep horizontally. Anyway, next slide. So I've put a picture here of a polysomnograph. So the polysomnograph is going to measure 3 different things. So there's the EEG, and the EEGs are looking at the electrical activity of the brain. This is a far less complex EEG than you would use when you're looking for epilepsy. So it's got far less probes, but it looks at the electrical waves during sleep. You've got an EOG, which are electrodes which are placed on the outer canthus of the eye. So it's an electrooculography, and ophthalmologists use this in very complex ways. But for the purpose of a polysomnograph, this is going to look for REM sleep. And then you have a submental EMG, but you may have EMG probes elsewhere on the body. And this is looking at muscle activity. So a polysomnograph will look at sleep, it will look at eye movement, and it will look at muscle movement. Oh, next slide. So what I've put here is a cardiorespiratory polygraph, and this is the kind of gold standard. But actually, what you've got at the top, and I can't use my arrow thing, but at the top is from where it says C3 to A2 down to REOG. This the red line, which is where it says chin, that is your typical polysomnograph. So that's your standard polysomnograph. And that's what the reading would look like. And the black lines are the the EEG. The blue lines are the EOG, looking at eye movement. And the red line is your EMG. The rest of it is the cardiorespiratory element, and also the probes that are on the abdomen and the chest to look for movement. And that's a gold standard. So that would be done in somewhere like the Evelina Sleep Clinic when you're suspecting sleep disorders or sleep apnea. Okay, so that little red square over there is kind of telling us something. Does anybody know why I put that square there? What it might mean? What state of sleep this person might be in? Okay, well, that's okay if you don't know, but if you do know, great. I can't hear anyone. So if I go to the next slide, and I'll just talk through the different aspects of sleep. Right, so we'll talk about the sleep stages. So sleep stages are comprised of two main phases. So you've got non-REM sleep, so non-rapid eye movement sleep, of which there are 3 types, and we number them N1 to N3, or S1 to S3, and you've got REM sleep. Now, in infants less than 6 months, sleep is characterized by active sleep, which is a precursor to REM, and quiet sleep, which is a precursor to non-REM. Next slide. Right, so here we have, if you look here, so in the awake state, you can see you've got the EEG, and then there's the EOG and EMG. So in the wake state, what you've got some lovely beta rhythms, okay? So these are quite low amplitude, high frequency electrical waveforms. Your EOG is going to be, the activity will be dependent upon eye movement and blinking. And then your EMG, again, just this some activity there, okay? So as soon as you go into sleep N1 or S1, your EEG starts to change. Okay, so this is a brief transitional period from drowsy wakefulness to a much slower EEG. And the waveform here is what we call theta waves, okay? And you get slow eye rolling movements, and this is when you get hypnic jerks and you start to have reduced muscle tone. So think of S1 as that period of time when you are sitting in a clinic in the afternoon, or listening to teaching in the afternoon, or sitting on the tube in the afternoon, and you start to drift off to sleep and then you suddenly wake. That's you going into S1, okay? And it comprises about 5% of your sleep. You then go on to S2. So you can see that there's a change here. So as you go into S2, this is actually signifying the onset of sleep, okay? And this is when you're going to start to see your sleep spindles. Now, if you look at the beginning of that S2 EEG waveform, you'll see a sleep spindle. You'll see that the frequency gets less, it opens up and it gets less again, okay? And then it's followed by a large, big negative deflection, and then a positive deflection up. Okay, so you've got the sleep spindles in S2, and you've got K complexes. So that big negative deflection, down and up is your K complex, and that's typical of your S2. And here your EOG isn't still not really doing very much. And your EMG, you can see muscle activity is just getting less and less. This is then followed by slow wave sleep, okay, or N3, S3. Okay, it used to be S3 and S4, or N3 and N4, but now we just put them as S3. Okay, and here you can see these are quite large amplitude, low frequency waveforms. Yeah, so they're quite different to the wake state. Your EOG, again, it's not doing too much, and your EMG is showing that muscle activity is really, really slowed down. Okay. You then go into rapid eye movement sleep. So here you've got a sawtooth appearance, high frequency, low amplitude, okay? There's a lot going on in your brain during REM. You'll know that REM is when you dream. Your brain becomes more active, your body becomes really relaxed. Look at the EOG. The EOG is showing you rapid eye movements. Those big high frequency deflections up. This is signifying rapid eye movement, and your EMG is flattened. And the reason why it's flattened is because during our REM sleep, your skeletal muscle becomes essentially paralyzed, okay? And that's important, isn't it? So why do you think it's important for your muscles to be completely paralyzed during REM sleep? So the reason why is because you really don't want to act out your dreams, do you? Okay, so you'd have heard stories about people acting out their dreams, because you can get REM parasomnias. Okay, so it's important to know the different stages of sleep, because at different stages of sleep you can have different types of parasomnias and disturbances. Okay, or I'll go to the next slide, please. Right, so if you guys all grab a piece of paper or wherever you are, and I've done, so on the vertical line, A stands for awake, and then you've got REM, sleep stage 1, 2, and 3, and then your hours going into sleep. So each line down is an hour. So if you could just draw what you think the sleep pattern overnight, your sleep wave would look like, your EEG. What do you think it would look like? And then you can show me on the screen and I can have a look, because no one's sharing themselves. So feel brave, show me what it looks like. All right, let's have a look. Yeah, I think that's a good one. That's a good one, Westmid. Good attempt. Okay, so, oh, next slide, please. Right, so exactly that. So what you've got is you start off in your awake state and then you go down. So it's a cycle, yeah? You go through all the stages and you go through these stages recurrently through night, okay? So you'll go through your, so obviously you don't go through your awake state frequently through the night, but you go through 1, 2, 3, 1, 2, 3, and then stay in stage 3, that slow wave sleep. And then you'd go back up and you'd reach REM sleep. Okay, now in children in particular, and I think if you have children yourself, you'll know that they go into REM sleep, and then after that, and actually can happen to some adults as well, is that you can drift off into a slight awake state after REM. But usually what happens is you would kind of stir, wake, but go back into sleep, and you're able to do that. But in some sleep disorders, so part of, I guess, sleep training is getting the child to acknowledge that they've come out of REM, or you acknowledging that they've come out of REM, and that although they've awoken, they still need to go back to sleep. Okay, so that's really interesting, I think, in children as well. And as you get older, your sleep cycle will change, and it changes quite a lot. So in older people, in the elderly, the REM is a lot less, and they have is a lot less, and actually there's much more frequent periods of waking, and so they're less able, as you get older, you're less able to consolidate that sleep. Okay, next one, please. So why do we need sleep? So, I mean, just amongst yourselves, just for a few minutes, or to yourself, just think about why you think you might need sleep. And I've put 3 categories here. I've put restorative, cognitive health, and emotional health. But why we alternate between REM and non-REM is not entirely clear. All right then, okay. So in terms of restorative, when you're asleep, you don't use as much energy. Okay, so you're going to use about 100 to 200 calories less. It's probably not a problem for us as we all overeat. We also know that, well, there are some studies which suggest that you are better able to produce an immune response. So there was a study where 2 cohorts were given the flu vaccine, and they checked the immunoglobulin responses. Sorry, can you go outside? I'm in the middle of something. So they checked the they checked the immunoglobulin responses, and the immunoglobulin response was higher for those who had had a good night's sleep compared to those who were sleep deprived. So I think that's pretty interesting. And then in terms of cognitive health, you know that you need sleep for memory. It consolidates memory, especially working memory. And then emotional health. So studies that show that that people are less labile, that attention is better, concentration is better. So it's so important for children, isn't it? And there's also studies in terms of cognitive health which demonstrate that children's academic ability is much higher if they sleep well. And actually, you know, that you need to get that, you need to have a really good sleep pattern early on in life, and that this will carry through later on. So there might be long-term impacts, okay? And something really interesting is that the theory behind REM is also that it reduces the emotional tone of your memory. So if you have an aversive event, if you're able to sleep on it in the morning, you're better able to assimilate, or the next day or whatever, you're better able to assimilate those emotions. It's less heightened in your mind. So really interesting. So I'm going to go on to the next slide. And we're going to finish off here. So I know people don't really know much about sleep, and we don't really learn it, and it's not a big part of our curriculum. But 20 to 30% of caregivers report that their children have trouble falling asleep and staying asleep. So I can guarantee that you will be asked about sleep a lot. And it's very easy to brush over it as it's just sleep. But the impact of poor sleep is immense. And if you go away and you start reading about this, you will find out that it's huge. This is a huge problem, okay? So my take-home messages are two things. I've put a reference to a paper that you can read, which is excellent. And I've also put the website to the Peers Network in Southampton, which run an amazing sleep clinic, and there's a plethora of information on it. And there's lots of information on it that you can go on to give to parents. Okay, I'm done.
Yeah, we've got a question here from Ramnik.
Can you hear me, Donna?
I can, yeah.
What's the role of melatonin? When do you prescribe melatonin? Unless you've got ADHD and sleep issues in a otherwise normal child. If they're really real issues with sleep, I mean, unless you refer them to sleep clinic or something, what's the role of melatonin? Can we prescribe it or chloral hydrate?
So I would veer away from chloral hydrate or antihistamines personally.
So did you say yes or no? For no.
So to answer your question, melatonin can be used. A lot of children have, and it doesn't have to be a long-term medication. So it definitely can be used if you find that a child is having difficulty settling to sleep. Yeah. So it's a medication that you can give at the beginning, half an hour before the child's due to go to sleep. But I would say before you give melatonin, you really need to do quite a comprehensive sleep history and find out what's actually going on, because melatonin is a quick fix, but often sleep is not. There's much more going on. So when you take that history, you need to find out what's been going on during the day, what's happening during the night, what the parents are doing, what's the parent's sleep pattern, what type of environment the child is in. There's always a lot more going on. What's that child's diet like? Are they having a bar of chocolate or hot chocolate before night? Because you'll know that chocolate contains caffeine, right? So does coffee, so does tea, so does green tea, so does some herbal teas. So all these things, you need to tease apart exactly what's going on. So yes, you can give melatonin. It's a pretty fix. It can be a quick fix, but is it really the right thing to do without addressing sleep hygiene? So I would always address sleep hygiene first. And if this family is really, really then struggling, then yes, I probably would trial melatonin. And the melatonin preparation you should give would be a slow release melatonin. So Slanito's a slow release melatonin, and it's much better at mimicking the natural release of melatonin, which induces sleep. And then oral hydrate and antihistamines, I don't give them. I wouldn't give them, and I think a lot of sleep clinics wouldn't give them either. But I know that there is sometimes a tendency in some places to give them, but it's not something I would do.
And we've got another question from Steve Tran. How does nocturnal epilepsy affect the sleep cycle?
How does nocturnal epilepsy
affect the sleep cycle?
Well, it will disturb your sleep cycle, of course. So if you're having epileptiform changes, then your sleep cycle will be disturbed. And there's lots of evidence to demonstrate that, and to demonstrate the negative impact of having uncontrolled epilepsy in sleep, causing developmental regression, speech regression, causing daytime somnolence, and causing cognitive decline. So this is there's no shadow of a doubt that poorly controlled epilepsy, especially in sleep, has a negative impact. Just because you're not able to get your proper sleep cycle in, I imagine.
And do we have any other questions for Lorna?
I just wanted to ask things like sleepwalking. What phases of sleep do they occur in? Because you were describing obviously like motor paralysis.
So this is a huge field, and what I would say is that what I wanted was to whet your appetite, and I think I can see that I have whet your appetite, but it's quite a big field, and that would be an hour's lecture in itself. So I think I'm going to bat that back to you and ask you to go and read up about it. It's really interesting because you can get different parasomnias in different types of sleep. Yeah. So sleepwalking, you can imagine it will be a non-REM, wouldn't it? Because you're sort of able to move your muscles.
Great. Well, thank you very much, Lorna. It was a really good session. We really appreciate it.
Lovely. Thank you, guys. Bye.
Bye.